shoulder surgery we're going to start talking about is something called the arthroplasty. What's the arthroplasty? The what? Well, the word arthroplasty, we tie it to the word replacement, yeah. And so we're just moving that in. And with the shoulder replacement, that comes to the understanding that you have the glenoid, you have the humerus, and those are the areas that we replace, because that convex and concave aspect of the joint, that's where you're going to see a lot of the arthritis, the osteoarthritis, and that's where you're going to need the replacement. Your book on 553 talks about 3 specific variations on this procedure. Number 1 is a total shoulder, and that is depicted in the book on page 553, where you see part of the prosthesis in the humerus right there, and that is the traditional total shoulder. Is they put a new prosthesis in the humerus, which gives it a new ball, and then they sometimes will do a little bit of repair on the glenoid, but that's a really little bone, so there's not much to do. And so what they found was that they could perform something called a reverse total shoulder, and that took and made a prosthesis where the glenoid, which once was convex, now has a concave ball on it, and they put a concave surface on the humerus in its prosthesis and reversed the ball and socket component, and that actually works better than what you see in this picture right here. With that being said, though, those procedures, they vary based off of what the surgeon wants to do. So you're going to see a variety of those. If you'll do me a favor, though, and turn over to page 554, there's some concomitant procedures, and you're going to hear this word several times, especially in this chapter. That just means other things that we do too. And that comes along a lot of times with the osteoarthritis issues. But you might see the bullets on page 554 down under operative procedures. Almost at the bottom of that column, it says concomitant procedures that may be necessary during shoulder arthroplasty. Repair of a deficient rotator cuff if the quality of the cuff tissue is sufficient. A capsular plication and tightening of chronic subluxation or dislocation. Anterior acromioplasty. What do you suppose acromioplasty means? Yeah, they're taking and they're shaving off and making some new acromion up there. A bone graft of the glenoid if bone stock is insufficient for fixation. So lots of things can be going on there, not just the fact that they put in a prosthesis and put in that new shoulder. Some of the things that we really want to pay attention to also is over on page 555, and that is immobilization. And so initially, that person is in a sling, and the picture that you have in your presentation here is of a very unique sling, and notice it has a strap that goes around the thorax. If you've had first aid, then you know what this is called. Anybody have an idea?
I had first aid, but I don't know what it's called.
Don't remember that one? I'm going to chastise your first aid teacher. So the sling goes across the uninvolved shoulder. It attaches down here to an envelope, right, on the arm, and that holds it up with the other part of the sling back here on this back side of the envelope. The strap that goes from here around the trunk is known as a swathe, S-W-A-T-H-E, and that just helps to bind that down even more. But this is a very common thing that you'll see most of our shoulder surgeries come out with. So they've got the shoulder in a sling and a swathe, and it varies as to how long they'll use those. But it could go up to about 6 weeks. Turn the page over And I want you to see some positioning components about what you're gonna have there. And that's all kept in box 17.5 on page 556. So we look at it and we see the word supine. The arm is immobilized in a sling that is worn continuously, elbow flexed to 90 degrees. The forearm and the hand resting on the abdomen. That's a really common thing to just keep them right here, but that's what that swath will do. The arm supported at the elbow on a folded blanket or pillow. Also, it says the forward flexion, 10 to 20 degrees, slight abduction, and internal rotation. One other area that we want to note is, just like we did with the humerus by bolstering it underneath, is that kept it from going into extension. You know how we have the hip and these things called precautions, right? And what are those precautions doing? When we have a hip replacement and we have hip precautions, those precautions are designed to reduce the risk of what happening at the hip, prosthesis. Yeah, dislocation. Same thing for the shoulder, is you want to reduce extension, because extension could cause that thing to pop out. And so we want to reduce that at that supine level. Sitting, the arm is supported in a sling, and then it says a rotator cuff repair down there as well. That's a concomitant procedure that you sometimes see along with that, because it just gets damaged from a lot of the osteoarthritis, and just age can do that as well. I do want to show you on the max protected phase on the next page, where we see that this person is usually hospitalized for around 3 to 4 days. That's really true with all joint replacements. It's just a massive amount of surgery to be done. Have you guys watched a replacement at all? Not just shoulder, but hip, knee, saw one. I mean, it's like going to a construction site, right? So lots of surgery. So they're going to be hospitalized for a few days. I don't know if 3 to 4 is quite accurate anymore. I think they're doing that a lot faster, but nonetheless, we just know that they're hospitalized. Goals, and that's over on page 558. Listen, this is how we do it in Ther Ex too. We talk about the goals, and then we kind of mash up what we know meets those goals, because the goals are our plan of care. What are the interventions? So the goal here is to control pain. Well, how do you control pain? Mostly with your modalities, but also it says your sling, use of cryotherapy, all these things we know. And then it talks about mobility of adjacent joints. All right, so go back just about 30 minutes ago, maybe more than that, probably about an hour ago. What did we say some of the adjacent joints were to the shoulder? Neck and scapula, right? So active movements of the spine and scapula while wearing the shoulder sling. So there you go. It talks about shoulder rolls and all those things. So your focus here in the max protected phase on every one of these surgeries, do the shoulder, do the neck and do the scapula, and you're going to be fine. It's not going to change. Next bullet, it says restore mobility, and it gives us passive range of motion. In the first sub-bullet. In the second sub-bullet, it mentions pendulum exercises. Now, there was one very critical instruction that we gave with pendulums. What was it? Huh? Use your hips, because it's not a shoulder active movement, is it? It's a shoulder passive movement. It also says that they may start wand exercises in sitting or standing. Also gear shift exercises, all things we know. And then self-assisted reaching movements to the nose, forehead, or over the head as comfort allows. And then in the final big bullet there, minimize muscle inhibition, guarding, or atrophy. How do you do it? Isometrics. And by the way, Hikari said isometrics. What phase of healing we talking about here? Max. All right, so real quick. Was this all just defined right there by what we just said? Passive range, yes. Isometrics, yes. Modalities, yes. It doesn't really get into the mobilizations, but if you were to refine your examination on Codmans, what you would find is that those are gentle grade 1, grade 2 oscillations. And so they do count as your mobilizations.
Question.
Yes, sir.
That bullet point talks about practicing those with the patient on the sound shoulder, and then immediately after says to postpone setting exercises for light isometrics of the operator shoulder from 4 to 6 weeks.
Okay.
Isn't that after the max protective phase?
Yes.
So I don't understand.
So I guess at that point, what I would say is any of the isometrics that we would be bringing in, it's going to vary depending on what they have done. And so I would tell you that not to argue with the book because we can't. I mean, the book's not going to argue back. What I'm going to say is when you see a shoulder and you're doing some of these exercises, almost always you're going to bring in the isometrics. Now, are you going to bring them in at week 1, 2, 3? It varies. This all goes back to, we don't know, did they get a total? Did they get a reverse? Did they get a hemi? And then from there, what does the physician preference say? And so at any point, they may say, only do passive range, don't do Codmans. They may say, you can do isometrics. I mean, there's all kinds of variations that are going to come into these. And so we're just kind of painting kind of a generalized picture of what it could look like. And then on each one of them, they're going to say, nope, can't do this, or yes, you can do this. Mm-hmm. And so for my best answer to that question is, we're going to present it to you and say, here's isometrics, but
Results may vary.
well, every surgeon's going to have a different go at it.
Yeah.
It really is.
Yeah.
So we move over, we look at the criterion to progress. Some of those very simple things are your range of motion, but also pain. So they would be lowering their pain, specifically isometric internal rotation of the subscap, and then down at the bottom it says for a little r TSA, so that's reverse total shoulder, criterion including tolerance of assisted range of motion and demonstration of the ability to isometrically activate the delt and periscapular musculature while the joint is positioned in the scapular plane. So then we look kind of down and we talk moderate protective phase. Also, there's a / controlled motion phase. Forgive the book, it's just going to continue to do it that way, but that's just kind of the way we talked about before. I'm not too worried that you look at the time frame there. More up north of that to the criterion. But the one thing I want to start with here is this precaution, and it's big in red. It says it is important to do so gradually so as to not irritate tissues which are continuing to heal. And then, just so we kind of see what that's directing on, look parentheses above it, stretching or resistance. Everything we do in this phase has to be very slow and controlled. We're going to cook that steak very slowly. But what we see on those goals number one, increase range of motion of the shoulder. So take a look at up here. Well, you don't have to look up here, but you can see the first thing I've got is the towel stretch. That's not to say that that's all you do, right? So give me some stretching maneuvers that we talked about in the last hour. What else can we do to stretch?
You got the table stretches.
That's where I would start, yes. But they also need to know what is the limit to that stretch. So let's go back to Ther Ex 1. I'm your patient. You're teaching me how to stretch my shoulder. And I say, well, how far should I go with this? What could you tell me that would keep me safe?
Don't increase your pain.
Okay? Not saying you're wrong, but there's pain. Right? There was a key word that we gave that separated pain out of the equation, and it said they should stretch to a level of discomfort. Remember that? So it's really critical for us to be mindful and say, you're gonna take that and it's gonna be a little uncomfortable. Now, the thing is again, they're not gonna be going very far. But that's a process. It continues to improve. It says that we will transition from passive to low intensity pain-free stretching, but that it should be discomforting. Turn the page over to 560. So we bring back in to here, pain-free, low-intensity submax resisted isometrics of the shoulder. And for this one, particularly of the rotator cuff. In the previous section, and just what we pointed out, it could mean that we're only doing our uninvolved shoulder. It could mean that we are only working with deltoid movements and not rotational movements. And so that's a big deal as well. For our second bullet, dynamic resistance exercises for the scapula and shoulder musculature. Help me out. What did we do that was dynamic for the scapula and the shoulder muscle?
Push ups on the bulletin board.
Okay, I don't know if they'll be ready for push-ups on the both two balls.
Oh, I thought you said what we're doing.
Well, try to keep it to this phase. Now, let's be clear too, that's a dynamic surface, unstable surface. Let me go back to just the word dynamic, meaning movement, as opposed to static. What do we do that was dynamic with our shoulders, but it would still meet criterion for a moderate protective phase?
Push up rows.
Probably going to bring in the band. The push-up plus I wouldn't say is wrong, because it's scapula, right? But what about the scapula? Think just the scapula. What can I do to strengthen that scapula? I can wall wash, right? I can table wash. I can bring in my push-up plus. one other thing that we really didn't demonstrate in the lab, and it's partially because I don't think the book does a great job of explaining this one. May I pull you back here? Is rhythmic stabilization of the glenohumeral joint. You probably did this in your labs, in your clinics, right? So what I'm going to do is I'm going to push in a variety of different ways, and I want you just to resist the direction that I push, okay? Most commonly we do this in supine, but since we don't have a table in here right now, right? So there is some really good, unique stabilization exercises. Open kinetic chain. Take a look down here and see what our criteria to progress is. Full passive range of motion, and then active anti-gravity elevation of the arm. Elevation of the arm is just simply flexion and abduction. And then a 4 or 5 strength. So that's pretty common all the way through. Any other thoughts on that one right there?
So you would do the wand on the max?
I'm sorry?
Would you do the wand on the max protective phase? Or the wand?
You can start. This one's largely going to be a depends again on physician preference, but many times you can start a wand exercise as long as they stay within the parameters of the range of motion which the physician will state they can do. So if they say they can go into 45 degrees of passive range, then yes, you can do the wand if they are appropriate cognitively and they show understanding. It really, I don't want to say it depends too much. I don't, because that's something that I feel like crops up a lot in this class as a response from me, but it does, it depends. What we have to do is we have to paint kind of a big picture, and then you take out what parts or components are appropriate for that patient in that situation. And it's all going to be dependent on what the doctor says they can and cannot do. Sometimes your PT will say, don't worry about it, let's just do this anyway. Well, that's a little risky. And in that event, I would almost say, you better have a lot of trust in that person if they tell you to do that. So it's only as clear as what we can make it. But the doctor gets the final say. You just work within their preferences many times. Just some quick looks here. In-range self-stretching. That doesn't necessarily mean that that's the stretch I would use. That's just a depiction to say you're going to get them into in-range. The neuromuscular control, I've got the shoulder taps, right? And again, that loads the joint with approximation, but also it's giving them a cue to go up and touch. So you get that neuromuscular control. Return to most functional activities. I do want to point this one out. Golf is kind of one of those things that comes up for total shoulders. The question for that age group, because it mostly affects older men and women, and so golf is a sport that many times they're participating in, and they'll say, can I return to golf? Yes. Will I be able to throw overhanded baseball? Maybe, but not very strong, right? I mean, it may be kind of a hard thing to do. So if they're softball, baseball, co-ed, church league, whatever, that may not be something they can return to. But golf, most commonly, they can. Also tennis. And your book talks about that on page 560. In the second bullet, under return to most functional activities, recreational activities such as swimming and golf are possible. Doesn't mean that they're gonna be great at it, but sometimes they can return. Let's talk about our impingements now.